So I'd like to really thank Dr. Nelson, Dr. Hoskins, and the organizing committee for inviting me to speak with you. Dr. Nelson asked me particularly if I would speak on the topic of the management challenges related to low-grade serous carcinoma of the ovary and peritoneum, and I'm happy to do so, and then hopefully we'll have the time for a few questions. I really appreciated being able to hear about Ovarian Cancer Canada, and I think you guys are doing great things there, so congratulations. So these are my disclosures. And these are the learning objectives of the talk I was asked to make in terms of understanding the details related to the clinical management of low-grade serous carcinoma, and also to understand the molecular biology of this particular subtype. So, we've known for many years that all epithelial ovarian cancers are not created equal, that they have very distinct clinical behaviors, but it's only been within the last decade that we've developed a much sharper focus on the heterogeneity of these tumors, and that's related, I think, to the refinement in pathologic diagnostic criteria, the publication of hypothesis-generating clinical studies, but most importantly, to advancement in the understanding of the molecular biology and genetics of the disease. In 2005, the GOG established the Rare Tumor Committee, and I think that really was very helpful in allowing us to develop separate clinical trials for women with rare ovarian cancer subtypes. And as you know, prior to 2005, all epithelial ovarian cancer was treated identically. There were essentially no prospective clinical trials for rare subtypes. But even then, we knew that one size does not fit all. So this is a listing of the studies of the GOG over a 30-year period from 1981 to 2011. We don't need to go into the details, but only to see that these were mainly frontline trials, some maintenance trials, in which all ovarian cancer subtypes were treated, and so no distinction. But we know that just because you've always done it that way doesn't really mean that it's not incredibly stupid. And I think when we look back, we could have started this initiative a little sooner than we actually did. So these are the three subtypes that the GOG, or now NRG, Rare Tumor Committee has focused on: clear cell, mucinous, and low-grade serous. But we're going to spend our time today speaking just about low-grade serous carcinoma. So in terms of the clinical management of early stage, as you know, comprehensive surgical staging is the standard. There certainly is a role for fertility-sparing surgery in selected young patients. Stage 1 low-grade serous carcinoma is extremely rare. In our database, we have only about 7 patients. But we believe, based on very sparse knowledge, that surgery alone is adequate therapy for these patients. But we also believe that for stage 1C, stage 2, and stage 3 disease, that platinum taxane chemotherapy remains the standard, although we'll certainly talk more about that in a few moments. For advanced stage disease, I think the principle is obviously maximum cytoreductive surgery to achieve minimal residual disease. The options, as you know, are primary surgery followed by postoperative chemotherapy, or neoadjuvant chemotherapy followed by interval cytoreductive surgery in patients who have very extensive disease. And how you determine that is an influx, I believe. We're doing a scope and score quality improvement project. CT scans have not been particularly predictive, but I think this is in evolution right now. The standard postoperative therapy is paclitaxel carboplatin, but with the variations of IP chemotherapy, dose-dense paclitaxel, or the addition of bevacizumab concomitantly and then as maintenance therapy. Now, currently, there are no frontline trials for the rare subtypes, although we've had two that we won't really discuss today. One was a phase 2 trial using an mTOR inhibitor in combination with the paclitaxel carboplatin for clear cell carcinoma of the ovary, and that's going to be presented at ASCO this year. And the other was a phase 3 trial with our colleagues in the UK for mucinous carcinoma of the ovary, and that was closed prematurely due to slow accrual. So we got very little information out of that trial. When we look at these three rare subtypes, most of the information, as you know, is about which therapies are ineffective rather than which therapies are really effective. Much of the evidence, if not most, is based on retrospective data or on post-hoc analysis of clinical trial data, not on prospective clinical trial data. But in general, all three of these subtypes share the property of being resistant to conventional chemotherapy. And when you look at the three rare subtypes, focusing on low-grade serous, it constitutes about 5 to 10% of all epithelial ovarian cancers. The vast majority of these tumors are advanced stage, 3 or 4, some stage 2, but very few are early stage, certainly stage 1. We know that these tumors tend to be much more indolent than many of the other subtypes, including some of the rare subtypes like clear cell. But it does share the property, as I mentioned, with mucinous and clear cell of being relatively chemoresistant to platinum taxane therapy. The outcome in early stage disease, again, we know very little about because it is so rare, but we believe it's excellent. But we know pretty well what the outcome is in advanced stage disease, and we'll talk more in detail about that. So our interest in low-grade serous carcinoma really sprang out of our studies back in the late 80s and 90s on serous borderline tumors. And we were particularly interested in borderline tumors associated with peritoneal implants, so-called stage 3 or 4 disease. Mainly stage 2 or 3 disease. And we were finding that as we reviewed these cases in great detail, that many of them did recur, and when they did recur, 75 to 80% of them were really not recurring as borderline tumors anymore, but they'd somehow transformed into low-grade serous carcinoma. And so that developed our interest further in studying this entity. And this is from a report by Mike Beer and his group that we collaborated with. It was an unsupervised clustering analysis of expression profiles of a number of ovarian tumor samples. All of them were serous, and what was found was that the low-grade serous carcinomas tended to cluster on the right there with serous borderline tumors and were very distinct from the high-grade serous ovarian cancers. So we know that low-grade serous carcinoma comprises about 10% of all serous carcinomas. It may arise in two different ways, either de novo or as a recurrence after a serous tumor of low malignant potential. And of all the serous LMP tumors that recur, about 75 to 80% do so as low-grade serous carcinoma. Of all the primary low-grade serous carcinoma cases, about 60% have coexistent areas of serous borderline tumor within the ovaries. And when we compare the overall survival and progression-free survival of de novo low-grade serous carcinomas with ones that recur after a diagnosis of LMP tumors. From the time they recurred as a low-grade serous carcinoma, you can literally superimpose the survival curves. And so that was very gratifying in terms of seeing those survival curves. So in 2004, our group reported kind of a new paradigm in terms of the classification of serous carcinomas, dividing them into low-grade and high-grade, dependent principally on the amount of nuclear atypia, but using mitotic count as a secondary classification parameter, with 12 mitoses per 10 high-power fields as the cutoff. And in that initial review, they reviewed 100 cases. And you can see when you compared the FIGO grading with the MD Anderson two-tiered grading, that there was very good concordance with grade 1 FIGO and low grade, only one exception in that review. Likewise, in the grade 3 FIGO compared to high-grade serous carcinoma was complete concordance. But the issue was in the grade 2 FIGO grading system, most of them were high-grade, but a number of them, almost a third, were low-grade. So we felt that this was a much more useful system. And in fact, subsequently, we retrospectively reviewed patients who had been treated with paclitaxel carboplatin on a GOG study, GOG 158. A panel of pathologists went back and reviewed all of the cases and divided them into high grade and low grade. And you can see that there were 21 cases with low-grade serous carcinoma in this cohort. And what was found when we reanalyzed the data was actually the outcome for patients who had grade 2 FIGO tumors was a little bit worse than grade 3. And so this was, I think, additional evidence that the two-tier system was more predictive. And actually, that the Hopkins group also published a paper that confirmed this as well. Now, there are some odd situations, very rare cases, where a borderline tumor may actually not go to low grade when it recurs, but actually go straight to transform into a high-grade serous carcinoma. We can also see, we see some patients who present with a mixture of low-grade serous carcinoma and high-grade serous carcinoma in the same tumor. And we're currently analyzing our cases. We have about 20 cases of patients that we have seen at our institution. So we'll be interested in what we find in terms of the clinical behavior of these patients. This is a study that Amanda Nichols-Fader published out of GOG data from GOG 182. And again, she used grade 1 FIGO serous carcinoma as a surrogate for low-grade serous, since we think there's good concordance as we showed. And she found what's been found in many primary cytoreductive surgery studies, that those patients who have no gross residual disease have a much better median progression-free survival and median overall survival than those patients who even have less than a centimeter residual or certainly greater than a centimeter residual. And likewise, Dr. Chen in 2014 reported a study that compared patients who had cytoreductive surgery, both low-grade serous to high-grade serous, and they found that in patients who had optimal debulking, there was definitely a difference in both progression-free survival and overall survival between low-grade serous and high-grade serous. But when patients had suboptimal cytoreductive surgery, those two graphs on the right, there really was not a statistical difference. So what about the primary treatment of low-grade serous carcinoma? These were the first two articles that our group published in 2006 and 2007. Our first publication was on 112 patients with stage 2, 3, or 4 low-grade serous carcinoma treated with primary cytoreductive surgery followed by platinum-based chemotherapy. But over 40% of those patients were found to have persistent tumor at the conclusion of primary chemotherapy, which we thought was definitely higher than one might see with high-grade serous carcinoma, for instance. And this study overlapped a period when we were still doing second looks back in the 80s and early 90s, and there was only a 5% negative second look rate in this cohort. You would expect that rate to be at least 30% based on the studies that were published on ovarian cancer in general. And so this was a preliminary data that suggested to us that these tumors may not be as, quote, chemosensitive as high-grade serous carcinomas. On the other hand, the median overall survival in that first study was 82 months, so certainly prolonged. And then in our neoadjuvant chemotherapy study, we reviewed 25 patients, 24 of whom were evaluable, and we found that only one of the patients had what was considered to be an objective response by RECIST criteria. Many patients had stable disease on chemotherapy given this neoadjuvant treatment, but there was a significant decrease in CA-125 values in 50% of that cohort. Now, the AGO just last month published in Gynecologic Oncology their experience. They reviewed 4 phase 3 ovarian cancer trials. They had over 5,000 patients. And in that cohort, they were able to identify 145 patients with low-grade serous carcinoma, of whom 39 had suboptimal debulking. They had CT scans prior to starting primary chemotherapy, and they found that those patients with measurable disease had only a 23% response rate. When they reviewed their 80 patients who had suboptimal high-grade serous carcinoma, the response rate was 90%. And again, I think this was confirmatory data that suggests that low-grade serous carcinoma is not as chemosensitive. In our recent update of our patients, we had 350 patients in our database. Again, over 40% had persistent disease at the conclusion of primary chemotherapy, median progression-free survival 28 months, and now our median overall survival was a little bit over 100 months in this group. And then when we looked at a subset, a very homogeneous subset of women who had primary surgery followed by platinum-based chemotherapy, stage 2, 3, and 4, on multivariate analysis, we found that those with persistent disease had almost twice the hazard ratio of those who did not have persistent disease. Interestingly, we found that patients with primary peritoneal cancer had a better outcome than those with ovarian. We're not able to explain that at this point. That was surprising to us. But we also confirmed one of our suspicions based on our clinical impression that younger patients have a worse outcome significantly than older patients. So patients younger than 35 did not do as well as those over the age of 35. And this is the survival curve from that study showing you the better overall survival in the older patients. So what is the standard primary postoperative therapy? So last year in the fall in Tokyo, the GCIG met again to update their ovarian cancer consensus conference from the one held in 2010 in Vancouver. I was not in attendance at that conference, but apparently they did decide that platinum taxane chemotherapy remains the standard treatment for low-grade serous carcinoma. If you were at the recent SGO meeting, you may have heard Amanda Nichols-Fader present her study, which was not a prospective clinical trial. It was a retrospective study. 26 patients with low-grade serous carcinoma treated with primary cytoreductive surgery followed by hormonal therapy, mainly letrozole. compared to 44 patients treated with surgery followed by traditional standard chemotherapy, and they found no difference in the median progression-free survival, 22 versus 21 months. For the last several years, we've been treating patients with surgery followed by chemotherapy and then advising them to consider hormone maintenance therapy, most recently usually with letrozole, although we've used a variety of hormones in terms of aromatase inhibitors, tamoxifen, luprolide, etc. And we're going to be presenting our results at the ASCO this year. This information is embargoed, so unfortunately I can't share it with you, but hopefully some of you will be in attendance to hear it. But there's no question, I think everybody agrees, whatever your bias, and there are certainly biases that have developed in the last few years based on the preliminary information, we all agree that prospective clinical trials are really very much needed to sort this out. CA-125, what role does that play in terms of the prognosis? Amanda, again, looked at GOG data and found that the baseline CA-125 in low-grade serous carcinoma was not predictive of outcome. It was, on average, lower than it was for patients with high-grade serous carcinoma, but she did find a correlation between the decline in CA-125 by the second cycle of chemotherapy or so and outcome in patients who have low-grade serous carcinoma. What about the treatment of recurrent disease? So we published a very small series, 41 women who underwent secondary cytoreductive surgery for low-grade serous carcinoma, recurrent. And what we found was, again, not unexpected, that those patients who had no gross residual following secondary cytoreduction on the left had a significantly better progression-free survival, and on the right, they also had a significantly better overall survival. But again, this is all retrospective data. What about salvage chemotherapy? This slide, it needs a little update. I think there were 58 patients who received 108 different salvage chemotherapy regimens. And overall, the response rate was less than the objective response rate by RECIST criteria, less than 5%. There was a very high stable disease rate of 62%. The median progression-free survival or time to progression was about 7 months in this cohort. So again, I think more data to suggest that this is not a very chemotherapy-sensitive tumor. We, like many groups, have used hormonal therapy in the treatment of recurrent disease for many years. And we also know that a pretty high portion of the low-grade serous carcinomas express estrogen receptor as well as progesterone receptor. And from one study to another, that frequency varies. So in 2012, we reported our experience with 64 patients with recurrent low-grade serous carcinoma who received 89 different hormonal regimens. The overall response rate was 9% in this report. Again, a very high stable disease rate, but the median progression-free survival, again, was right around 7 months, 7.4 months. The 6-month progression-free survival was 61%. We did see a trend in the patients who were ER-PR positive, tended to have a better outcome than those who were ER-positive, PR-negative, but it didn't quite reach statistical significance. And again, it's retrospective, so I think we have to take that with a grain of salt. We do need further study on the relationship of response to ER-PR status, though, in this disease. These are the 8 patients who experienced a response. There were 6 CRs and 2 PRs. You can see most of the patients had peritoneal cancer. Most received letrozole. Most were platinum sensitive. And the ones for whom we had data, most of them were ER positive, PR positive. One of the complete responders was ER positive and PR negative. We also believe that bevacizumab is active in this disease, in low-grade serous carcinoma. In 2010, on the right, Kathleen Schmaler reported our information with bevacizumab in the treatment of patients with recurrent low-grade serous carcinoma. Most of the time, it was in combination with chemotherapy. Response rate was 41%, and we are currently updating that series to publish it. So it's been a while since that was reported at ASCO. But Rachel Grisham from Memorial Sloan Kettering published their data in 2014, a very similar cohort, 17 patients, response rate to bevacizumab with chemotherapy or as a single agent was 40%, stable disease rate 33%. But it's interesting that in the update, in the publication of the ICON 7 trial in 2015, Amit Oza showed that in patients, this was a comparison of platinum taxane chemotherapy plus or minus bevacizumab concomitantly and then as maintenance, that in the patients, and I know you probably can't see it very well, that in the patients who had low-grade serous carcinoma, that the addition of bevacizumab made no difference in the frontline setting. So that was a little disappointing. But again, very small numbers, and it wasn't powered to really show a difference. So now a little bit of discussion on the molecular biology of low-grade serous carcinoma. We know that the MAP kinase pathway is very prominent in the pathogenesis of this disease. Excuse me, but we also know that the RAS gene may affect the PI3 kinase AKT mTOR pathway as well. And there is an emerging story based on several publications, so that we now know that BRAF mutations occur in up to 40% of serous borderline tumors, but we think only in about 5% of low-grade serous carcinomas. So we believe in some way BRAF mutations that occur in borderline serous tumors somehow protect them against the transformation or recurrence as a low-grade serous carcinoma. We're not sure how that occurs, but I think there's now increasing evidence that that's the case. KRAS mutations occur in about 40% of borderline tumors and in about 30 to 40% of low-grade serous carcinoma, so there's pretty good concordance there. There's also a little bit of data that suggests that women whose tumors have a KRAS G12V mutation have a worse prognosis than those that have either a KRAS G12D mutation, wild type, or a variant. And of course, for high-grade serous carcinoma, BRAF mutations have been found in virtually none of these patients, and KRAS mutations in only up to about 14% of high-grade serous carcinomas. This is the survival curve from our report in 2013, small number of patients, but indicating that there may be a worse prognosis associated with a KRAS G12V mutation. This is a trend that's been seen in a large number of colon cancer patients as well as in lung cancer, non-small cell lung cancer. This is a table from a review article on BRAF related to borderline tumors and low-grade serous carcinomas. And as you can see on the left, the rate of BRAF mutations in borderline tumors, serous borderline tumors, is pretty high. But again, most of the series have shown, except with the exception of the first report by Singer in 2003 that showed a 32% frequency of BRAF mutations, all of the other studies have been in the 5-10% range or so of BRAF mutations. And so I think they overreported probably because they were including some micropapillary borderline tumors that were non-invasive combined with some of their low-grade serous carcinomas. Other groups have also reported similar findings, particularly the notable is the NRAS mutations, 26% frequency in this report by Hunter in 2015 of NRAS. We've also seen some HRAS mutations as well. This is a report from Rachel Grisham from Memorial Sloan Kettering last year. It was focused on a 51-year-old woman who had a complete response on GOG 239, which I'll discuss in a moment, treated with selumetinib, MEK inhibitor, and then they expanded that and looked at other patients, and you can see the CT photos of from this patient showing a complete response. But they expanded and looked at other borderline and low-grade serous carcinomas, and they found a number of aberrations in the MAP kinase pathway that were not explained on the, simply by having a KRAS or a BRAF mutation. There were other aberrations, deletions, fusions, and so I think this just underscores the fact that we don't very well understand how the MAP kinase pathway really is the circuitry of that pathway and how it plays into the correlation with response to, for instance, MEK inhibitors or BRAF inhibitors. We don't think of low-grade serous carcinoma as being part of the breast ovarian cancer hereditary syndrome, but in fact, in this report by Norquist and JAMA Oncology late last year, about 6% of women who had low-grade serous carcinoma did have a BRCA1 or 2 mutation. You notice that some of the other genes that are of uncertain significance were not mutated in this small group, 55, or rather really about 58, 59 patients with low-grade serous carcinoma. So it does occur, but it's pretty unusual. We also found in one of our studies that insulin growth factor 1 may be overexpressed in low-grade serous carcinoma compared with either borderline tumors or high-grade serous carcinoma, and this could be potentially a target for therapy. I don't know of any specific trials that have tested IGF-1R inhibitors in low-grade serous carcinomas yet. This is a study unpublished from our group in which a low-grade ovarian cancer cell line was treated with 2 doses of trametinib, which is a MEK inhibitor, and we found what you would expect: downregulation of phospho-ERK in this cell line. There was also downregulation of CHEK1, and there was compensatory upregulation of phospho-AKT, which again we expected. So it did kind of confirm our expectations to some degree. And then when we treated another cell line with a combination of a MEK inhibitor, trametinib, with 2 different doses of a PARP inhibitor, olaparib, we found some synergism. And so there's some preclinical evidence to suggest that possibly combining a PARP inhibitor and a MEK inhibitor may be beneficial, but to my knowledge, that has not been done in this cohort. But there are a number of studies, including this one as an example, on all kinds of RAS-mutated cancers, not just low-grade serous carcinoma, that have shown that when you combine a MEK inhibitor with an inhibitor of the PI3 kinase AKT-mTOR pathway, you may find a synergistic effect. We published last year our findings, again, sort of based on our initial clinical impression. This was 79 cases of low-grade serous carcinoma, all of which underwent Sanger sequencing and not next-gen sequencing at this point. And we did find that there was the patients whose tumors had a KRAS or BRAF mutation had a significantly better overall survival than those women who had wild-type KRAS and or BRAF. That's preliminary information. It really needs to be confirmed. So what are the pathways and the potential targets for in low-grade serous carcinoma? Of course, the MAP kinase pathway we've mentioned in terms of MEK inhibitors or BRAF inhibitors, possibly IGFR1. The angiogenesis pathway, as I've shown, I think is a pathway that specifically could be a target and is a target for low-grade serous carcinoma. PI3 kinase AKT mTOR pathway, even though there are very few aberrations in this pathway, it seems to interact significantly with the MAP kinase pathway. So I think combinations of therapy need to be exploited more than they have been. And of course, the traditional classic target is estrogen receptor. So a little bit about some of the studies in the last few slides. So GOG 239 was opened in 2007. It was a phase 2 trial that accrued 52 patients with recurrent low-grade serous carcinoma. All of them were confirmed by prospective pathology review, treated with selumetinib, a MEK inhibitor. This was the publication in 2013. But what we found was that there was a 15% response rate in this cohort, which seems low, but was certainly better than we had witnessed or observed with chemotherapy or hormonal therapy. The major toxicities were dermatological, skin rash, GI, diarrhea, nausea and vomiting, or fatigue. On the left here shows you the number of cycles that the patients received. So there is one patient who's being treated at our institution who is still receiving selumetinib several years after this trial was activated, and she's still in remission. Unfortunately, there was no correlation. We had 34 patients for whom we had formalin-fixed paraffin-embedded tissue. We looked at KRAS and BRAF mutations and found no correlation between response and these mutations. But again, I think it highlights the fact that we don't understand this pathway very well. But there are also problems related to this analysis. This is a patient who was in that study, treated at our institution, who had a partial response to selumetinib. She happened to have a KRAS mutation. These are also unpublished data from this trial. We looked at phospho-ERK by immunohistochemistry, and we found that those patients who had a higher level of phospho-ERK were more likely to respond. And so again, the pathway was activated. They may or may not have had a mutation, but somehow the pathway was activated and they were more likely to respond than those patients who had a lower phospho-ERK score. But again, there was no direct correlation between having a high phospho-ERK score and having a BRAF or a KRAS mutation. So it's more about other aberrations that are occurring in this pathway. We also know that BRAF inhibitors may be active. This is a report of non-melanoma cancers, and there were 2 or 3 low-grade serous carcinomas. This is one of them in a patient who had a partial response to a BRAF inhibitor, and there are other reports of responses to BRAF inhibitors in low-grade serous carcinoma. There have been 3 trials recently that are studying that are follow-up trials to the GOG 239 trial. This is the Milo trial that is a randomized phase 3 trial of standard of care physician's choice, one of 3 chemotherapy agents versus a MEK inhibitor. And as you probably know, this trial crossed the futility boundary and was a couple of weeks ago was closed to patient accrual. We don't know the details about this. They won't probably come out for another year or so, but the rumors are that this was based on independent radiologic review. But for whatever reason, the monitoring board decided to close this trial based on futility, which was obviously disappointing. There was another trial that combined another MEK inhibitor from Merck with a PI3 kinase inhibitor or a placebo. This trial was also closed prematurely, but based on toxicity, not on futility. And the third trial is still ongoing. This is a GOG 281. That's an international trial with our colleagues in the UK. This trial is a 250 patients, phase 3 comparison, again, of standard of care, either one of 3 chemotherapy agents or 2 hormonal agents versus trametinib, which is yet another MEK inhibitor. This trial has accrued 121 patients to date. We anticipate it'll be open for maybe another year and a half or so. It does have a futility analysis, but that occurs rather late in the trial. So this trial is the only one of the 3 that remains activated. So what are the future directions in the study of low-grade serous carcinoma? I think we need to continue to study hormonal therapy and to refine its role. And also we need to know a lot more about the correlation of response to hormone receptor expression. We need to continue to find out if MEK inhibitors are really active in this disease and how active they are, and what are the factors that cause resistance to MEK inhibitors. Are we going to be more effective if we combine them with other targeted agents? These are all questions that I think need to be answered in a prospective clinical trial. Just wanted to acknowledge our group at MD Anderson in terms of the low-grade serous tumor research, colleagues who've really contributed to many of our studies. And so in conclusion, I would say one size does not fit all. Certainly low-grade serous carcinoma is very distinct from high-grade serous carcinoma, clear cell, mucinous, etc. So thank you very much for your attention.